session, we have with us Dr. Subhash Chandra Bhardwaj. He is a professor and head in the Department of Pathology, GMC, Jammu. Along with him, we also have Dr. Swayamprabha Pradhan. She is a professor and head in the MKCG, Bengaluru. So today's talk will be presented by Dr. Komal Meherbano. She is a retired professor and ex-HOD in Government Medical College, Nagpur. We have few students with us. So the students, please introduce yourself.
Just hold on. Madam is from Berhampur, not Bangalore.
Yes.
Sorry, sir.
Students to introduce themselves.
Good evening, everyone. This is Dr. Sadamini Agarwal. I am JR2 Pathology in Rohilkhand Medical College and Hospital, Bareilly.
Good evening.
I'm Dr. Salman.
Good evening, everyone. I'm Dr. Purnika Tombram, second year postgraduate in Sri Siddhartha Medical College, Stuttgart.
Good evening, everyone. I'm Dr. Salman. I'm a postgraduate third resident in Silchar Medical College, Silchar, Assam.
Good evening, everyone. I am Dr. Fatima Sheikh from NKP SIMS, Nagpur, Maharashtra. I am a final year resident.
Next.
Good evening, everyone. I am Dr. Chandana, third year resident from AIIMS Bhopal.
Next.
Good evening, everyone. I am Dr. Preeti from Kempegowda Institute of Medical Science, Bangalore.
Next.
I think everybody is introduced. Over to Madam, I think.
Good evening, everyone. And the Sakti, third year PG from JNMC Wata.
So
Shala Sutta is muted. You have to unmute Shala? Anyway, Dr. Kamal, please, it's over to you. You have to make your screen full. We can't see it full screen. Can you just make it full screen?
This is fine.
yes, ma'am.
Yeah, it's perfect. Thank you.
Okay.
Yeah, good evening, everybody. It's always a pleasure to be with the residents and faculties. And thank you, Dr. Bojes ma'am and Dr. Sumit Gujral for giving me this opportunity to interact with you all. I hope you all are very excited about this evening. Are you feeling excited or not?
Yes, ma'am.
Yes,
Yeah. So could you read what all I had extended in the group?
Yes.
Have you taken time out to read something about fluid cytology?
Yes, ma'am.
Yeah, that's nice. And overall exfoliative cytology, I find that the residents find it a little more difficult as compared to fine needle aspiration cytology, which seems which you can learn in a short period of time, even with your short postings that you get for 3 months and then 6 months. But exfoliative cytology really requires some good amount of time and experience, and the cells that you have to see, they really need to be demonstrated. So one big branch of exfoliative cytology is cervical cytology, and the other is the fluid cytology. Now fluids can come from different parts of the body, so we'll be talking all about that. And now I'll be very natural, I'll not be very formal, and I'll be asking questions on even the initial presentation that I'm going to give right now. Dr. Sumit had told me that initially you show them some 15 minutes, some material, and then we can go over to the cases. I hope you have seen the cases. All of you, have you seen the cases?
Yes, ma'am.
Yes, ma'am.
Yeah. Could you interpret them nicely? Or you had some difficulties? Were they very difficult or they were simple cases? Okay. So, pardon, Dr. Subhash?
They were good cases, I must say.
I have kept them very simple, and
Yes.
we'll be, they were just pictures to begin with so that we could build something on that.
Yeah.
And then I think we can go ahead. Now, I would like to join for this initial period. I want Dr. Shakti
Yes, ma'am.
from Sagar. Yeah. So you'll be with me for this initial presentation, and if I feel like asking few questions, then you're going to answer them
Yes,
on behalf of all others. So
yes, ma'am.
what are we seeing? What are we seeing over here?
I can see the lungs, heart, and liver.
And the abdomen.
Yes, ma'am. Abdomen.
And basically, I'm demonstrating the three major cavities that we are supposed to, where the fluid accumulates and from where the fluid comes to us for cytology.
Yes.
Now, what is the significance of collecting fluid? You can have nodules in the lungs, you can have nodules in the peritoneum, you can have nodules anywhere else where the cavities are present, even like the synovial cavity of various joints. But targeting the nodule, that is very nicely shown in this, targeting the nodule is slightly difficult, and you may miss the target and may not get sufficient material. So what is more convenient? It's shown very nicely over here. As if along with the nodule there is accumulation of fluid in the body's cavity space, you can collect the fluid and study the fluid. This is what the slide is telling us. Now, you all are very familiar with the terms. Shakti, tell me.
Yes, ma'am. And that way, two causes, transitive causes and exudative cause. The accumulation of fluid in body cavities is pleural effusion. It may be transitive and exudative. Transitatives causes are mostly congestive cardiac failure due to increased hydrostatic pressure or reduced oncotic pressure. Then cirrhosis of liver due to decreased oncotic pressure. Then hypoproteinemia.
And the decreased oncotic pressure is basically because of decrease in the albumin in the blood.
Yes,
and
ma'am.
the decrease in albumin can be because of various factors where albumin is produced, particularly liver and in malnutrition.
Yes, ma'am.
And then you have the exudate. So I put it, very clearly on this, so we need not harp on it much. And I think you also all know very clearly what are the differences between transudate, exudate. You all go through it, this in your undergraduate, and it's just a revision. So let us move. When all do we get fluids for cytology? What are the different situations? Yeah, tell me. It's all written over here. I have not animated it, so it's easy for you. The first situation, Shakti?
Yeah, first is clinical radiologically obvious malignancy. Clinically.
So in your section, you get a nice history, and the radiological findings are showing that there is a growth in the lung, and clinically also the patient is showing all signs and symptoms of malignancy. That's one very obvious situation. Second situation?
Biopsy proven malignancy at the time of fluid was collected or received.
Sure. The next situation?
Third is from history of biopsy proven malignancy in the past.
Now, what is the difference between these two?
Any secondary cause to TB malignancy.
No, we are talking about frank malignancy. Here, in the second situation, the biopsy was taken, and the patient came along with a growth and presented along with effusions in any of the body cavities. So the patient was in enough good health that they could take a biopsy from her and also send the fluid for staging to the department. But here in this history of biopsy proven malignancy in the past. So what does this tell us? In the past means how long it could be.
Since 1 year.
It could be any duration. So it just tells us that the patient was in the process of diagnosis. Many a times patients travel to us from long distances, and the biopsy has been taken at their hometown, and then they are sent to the referral centers. So she just comes with a report of the biopsy along with her, and the report says that there is a malignancy, and the duration from the time the biopsy was taken and to the time the patient presented to us can be as long as 1 month to 1 year, or maybe more than that. So that holds its own significance. What's the fourth situation?
Patient chemotherapy and or radiotherapy treatment.
Yes, so already she's diagnosed completely, and she's already on chemotherapy and on radiotherapy, and from these wards you are going to get fluids from any of the body cavities. And the fifth situation is in the center that I have shown.
Medical conditions.
Yeah,
Any
so we know what are the different medical conditions you can immediately remember?
ma'am, cough, chronic cough.
Yes, that's very common in developing countries. So all the conditions that we have talked about previously.
Hemoptysis,
Any other condition? Any kidney disorders? Renal failure?
CKD, ma'am.
Yes, CKD. Then malnutrition we have talked about. So there could be n number of medical conditions that can give rise to, apart from malignancy, that can give rise to accumulation of fluid in the body cavities.
Yes, ma'am.
Now, before we just take this annotation request is coming, can we decline? Can I decline it?
Yes, ma'am, please.
So each time I have to decline it, or somebody has made it?
No, ma'am, please decline it.
Okay, so before we approach systematically to effusion cytology, I would like to know how much fluid is required to be collected in any of the cavities before the patient presents with symptoms of that particular site. Suppose he has accumulation in the pleural cavity, so he will present with dyspnea. If he has in the abdominal cavity, how will he present? Shakti, how will he present?
Ma'am,
Distension of abdomen, discomfort in the abdomen,
abdominal distension.
pain in abdomen, heaviness.
Any tenderness.
Yes, all these symptoms will be present. I'm getting this annotation request. Please tell them.
Ma'am, every time, please decline it.
Okay, I have to do that. Okay, no problem. So how much minimum amount of fluid should accumulate in the body to cause discomfort? Say in the pleural cavity. Any idea? Say some 300 to 500 ml of fluid minimum is required before there is dyspnea or discomfort in breathing, or there is chest pain in a patient. And for the abdominal cavity, will it be more or will it be less?
More, ma'am.
Yeah, naturally. So it can accumulate a lot of fluid, so you can have sometimes 1000 ml, and even 1000 to 1500 ml can sometimes be accumulated, and still the patient may not be symptomatic. But for the pericardium, what is the situation like? Yes, Shakti. Pericardium, can it tolerate any amount of fluid?
No, ma'am.
Yeah, so it's a very minimum amount of fluid is somewhere between 50 ml to 100 ml that will start causing him all cardiac problems. So this is just general information. Now, when we come to the approach to effusion cytology, we have these different approaches, and we'll just take a note of these. Now, in the general approach, one thing is very clear. Shakti, you can read the first point.
Yes, ma'am. Proper clinical and radiological details are a critical component for optimum interpretation.
So do you think without any clinical findings of age, sex, signs, symptoms, can you understand, or radiological findings, can you interpret the fluid?
No, ma'am.
Yeah, it's just not possible. So every fluid has to be understood or interpreted in a proper clinical and radiological context. That is the most important part. Now, to get all these these details, it's not always the clinicians. We are not anytime at the receiving end, so we always have to request for these findings. Only rarely do we get all the information of the patient on the requisition form. What is the second point?
Ma'am, even during the stage of specimen processing, clinical information is important.
Yeah, so you just can't say that okay, the specimen has come. I have not made any slides, so it's okay. I don't need the information. I will make the slides and then I will ask them for clinical details. Will that be helpful, or it will be a deterrent for your interpretation?
No, ma'am, it is helpful. Not helpful.
What will be more helpful? Having the clinical details while you're still processing the specimen. Why?
Because you can decide the board of processing.
Yes, you have many options.
Yes.
So depending on we will see those options. There and there you can decide whether you want to make a cell block, or whether you want to submit the sample for flow cytometry, or you want to make some special stains or do AFB staining. So all this can be decided depending on the quality of the fluid that you have received. The third thing, I think the third point has been covered.
Yes,
Read it out, Shakti.
Cell blocks for elective immunohistochemical evaluation, samples for flow cytometry.
So all these decisions can be taken while you are still processing the sample. Now, if I have to go in very short, whenever the fluid comes to you, now generally I don't know what is the procedure in different medical colleges. It is our attendants who receive the specimens on the windows. Dr. Subhash, am I clear? Do you agree with that?
Definitely, ma'am. Our technicians are the ones who receive it.
Yeah, attendants,
Yeah, and
technicians.
of course, residents are with them in the lab, and the instructions they already have been conveyed to them how to receive them,
Yes.
in what containers, and how to process them.
So
But
once
it is the technicians who receive it.
yeah, so once the technician receives it, and I personally feel that residents should be interpreting the fluids in terms of its gross appearance. How is it turbid or clear? What is the color? Because each of these things will give you some amount of information. So Shakti, can you read this out for me?
Yes,
You
ma'am.
will, in melanoma, what will it be looking like?
Chocolate brown color, madam.
Then, if it is a hemorrhagic specimen,
Maybe malignancy is.
the commonest cause is malignancy in hemorrhagic specimens. How does the fluid look like? What is the color? It will be paler, lighter brown, golden brown. That would be the color because of the old lysed blood. If the patient has jaundice, which is a very common situation, or there is leakage of bile, again it will be greenish or dark brown, orange in color. And in mesotheliomas, how will the consistency be?
There is increased viscosity.
Yes. And it's a very thick viscous fluid, and sometimes they call it like thin honey type of
Jelly.
appearance,
Jelly-like.
consistency. And in pseudomyxoma peritoni,
It may be gelatinous mixture, mucinous.
mucoid, gelatinous, or a jelly type of. It's called a jelly belly situation, where you have that thick gelatinous aspirate, and sometimes it's very difficult to even pull out the fluid out of the abdomen. So I've just put randomly very few examples. So for every situation, you have all these gross findings of the fluid. Now, how much fluid is required for to give you adequate number of cells?
Around 50 to 80, 100 ml of fluid, normal.
So less than 50 would be, would you reject any specimen which is less than 50 ml? Say just 20 ml, sometimes you just get in a penicillin bottle, 5 ml.
Ma'am, normally volumes are fluids in the cavities are 10 to 20 ml.
No, the surgeons remove large volume of fluids in malignant patients. They want to relieve them of their symptoms. That distended feeling is there, so they will sometimes remove 200, 300 ml. Decompensation has to be done so that the symptoms are relieved.
And there is no upper limit, there is no.
Okay, that's right. There's no upper limit, depends on the clinical situation. And then should we ask them to submit all of the fluid to the lab, or they can send only a part of it? What is the general practice? Whatever
Some
we,
some of the fluid, not all fluid.
Yes, so in that sum of the fluid, you can, an optimum amount should be like, if it is a huge aspirate, so they can submit around 100 ml, but a minimum threshold is 50 to 75 ml.
Yes.
Now, so, you can encourage the clinicians to send as much fluid as possible, but it's very difficult for the lab to handle. So even when we convey to them, they do submit as much fluid. They have some of the physicians, and mainly that is done by their paramedics in the ward. So they submit large amounts, but it's difficult for us to process. Now, and it's nothing like that. If you have more volume, you will have more diagnostic samples, but an optimum volume of up to 75 or 100 ml or minimum of 50 ml is essential. Now, what is adequacy in terms of cellularity? Now, we all know that there is no such state as a normal effusion. Anytime effusion is a pathological condition. Okay. Now, once you receive the specimen, you have to decide whether it is adequate or not in terms of volume. So that we have already talked about. And then when you make slides out of the sediment, we will see the different methods that you make. You start seeing the number of cells. Now, and depending on that, you will have a different amount of cellularity, and depending upon the different clinical situations, you will have different cells. This slide should come a little later. Now, when we have looked at the specimen, written all the gross findings of the specimens, you start processing the specimen. Now, what are the different methods of processing? What is the mode of processing in your institute, Shakti?
Direct
Hmm.
direct smear of the concentrated effusion of the then cap stain and Giemsa stain.
Okay, you do two stains, pap stain and the Giemsa stain. So what do you do with the specimen? What do you understand by direct smear of unconcentrated effusion specimen?
Or for cell count.
Here you are just taking a small drop of the fluid. See, it's a direct smear. You're taking a small drop of the fluid and putting it on the slide, and with the help of toluidine blue, 1 drop of toluidine blue, you are mixing the fluid and the toluidine blue, and then you are putting a cover slip and looking at the specimen under the microscope to see the cell count, or not exactly the cell count, how is the cellularity of this fluid. It is not sedimented as yet. So many institutes, they prefer using this type of fresh mounted specimen with toluidine blue stain. It gives you a lot of information. So the departments that do this type of processing, they are very much convinced that it gives them a lot of guidelines regarding the nature of the cells, distribution of the cells, whether they are dissociated or they are in clusters or they are in cell balls, etc. So it is a practice which it depends from department to department. Now, this second most common method is the sedimentation method. You sediment the specimen and you spread it. Now, how do you spread such a smear? How do you make these sediments? What do you do exactly?
One more for thick smear and thin smear.
That is the third thing. Now we are talking about a sediment and
It should be tongue
tongue-shaped
separate.
smear.
It should be tongue separate.
Pardon? Sorry?
It should be a tongue separate smear. Sediment.
It should be a tongue-shaped smear. Okay, but before that, what do? You take the fluid into a test tube, and then what is the time? What is the RPM? How the sedimentation is done? And before that, you want to do anything? Before you're putting the fluid into the test tube, you want to do anything? You want to see any particles? If there is any blood clot, you have to just squeeze the blood clot, remove it. And if you feel it's from a malignancy, then you can just keep the blood clot apart for a cell block. And then rest of the material can be sedimented. What is the speed and time? That's the basic thing. For how many minutes you have to sediment? At what speed? 2000 RPM for about 5 minutes. And that gives you a small cell button at the bottom. And from there, you have to decant the supernatant and then make tongue-shaped smears from the sediment that has come. Then another thing that is sediment in this same process is the thick and thin smear. Who does this thick and thin smear? In any one of you in the residents who are present here? Madam, do you do this technique? And what is this thick and thin technique? हाँ आप निकल जाओ चाबी ला के दे दो. Okay, so I'll show you these in the forthcoming slides. Then you have the cytocentrifugation or the cytospin smears. I think this is done in most of the institutes. And then you have the liquid-based preparations, you have the millipore filtration, and then you have the cell block. So the decreasing amount of letters that you can see in each of these procedures is directly or indirectly correlating with the area of the cell spread that you are getting. So the cell concentration techniques are becoming, the area of the cells is becoming smaller and smaller with these different types of methods. Now this is what we were talking about, the Toledan blue wet stained wet film. They can stay in the refrigerator for long periods. You have just put a cover slip and then you can identify many conditions through this. And this is the tongue-shaped smear. Now, each of these methods has its own advantage and disadvantage. What is the disadvantage of the tongue-shaped smear, Shakti?
Ma'am,
Logically, all these cells, they tend to accumulate at the edges of the smear. So you
Yeah.
have less number of cells in the center, more at the periphery.
tail.
Pardon?
Less number in the head, but more number in tail edges of the cell.
Yes, they accumulate over there. So when the cells accumulate in one area, you cannot see the morphology of the cells. When there is too much accumulation of the cells, it's difficult to see the nuclear and cytoplasmic details. Now, what is this method we were talking about? This is the thick and thin method. I think this method has been indigenously developed in our department in GMC Nagpur, and ever since we have been using this. We do not make tongue-shaped smears. We do have cytospins, but this is the commonest method we do. So with a small plastic sort of stick, or initially we used to do with a matchstick, you have to take the sediment on the slide and then just drag the stick and touch it to the slide. Drag the stick and touch it to the slide. So wherever you are touching the stick, there is cell concentration, and wherever there is, you are dragging the stick, there is spread of the cells, which gives you the morphology. So this is the area between two area where you are seeing better morphology, and here you are seeing the cell concentration. So you have an idea of both cellularity as well as you have the idea of morphology. And this we have been using since almost 20 years in the department. Anybody else is doing this method?
Yes, ma'am. Yes. We also, especially the fluids which are thick, like colloid or some serous fluids. So we can also make thick smears when we make their centrifuge deposits. So we using the edge of another slide, we can make thick thin smears.
Yeah, exactly. Either you use a stick or you can use the edge of another slide.
Yeah, we can.
Now this is the membrane or the millipore filtration, which was used initially, and I think still some departments are using, and I think PGI Chandigarh is also using this setup, where you have the whole system. There is a funnel, and then there is a millipore filter attached over here, and with the help of suction, the fluid is sucked up and all the cells, they are left back on the membrane. And then this membrane is either cut into two half and put on the slides, and either the membrane is dissolved and the cells are stained, or along with the membrane, the cells are stained. So these methods are, but these are very physically demanding. Each sample takes a lot of time. So that's why because of the complexity of the method, they have stopped using it in many places. Now, cytocentrifugation this is the cytospin method. This is again a very mechanized, simple method. And what happens in this, Shakti? How are we going about this specimen? What is this method like?
Cytospin method.
What is the difference between say millipore filtration and in this? Here also there is a filter card in this. No idea. Anybody else? See, you can get a small, yeah. Yes. See, there are filter cards. There is a hole in it, and then behind the filter card there is a slide. And because of the spinning force, this vial is spinning in the cytocentrifuge, as well as it's depositing the cell on the slide. So these two processes are going on simultaneously, and you get a small diameter of cells and on the slide. And what is the use of the filter card in this? It absorbs the excess of fluid. Now, what is the advantage, disadvantage of this method? Like we talked about the disadvantage of millipore filtration. What is the disadvantage of this method? Shakti? Anyone else?
Ma'am, for the advantage is that it concentrates the cells many folds. So
Yes.
a maximum population can be seen within a very small surface area.
Okay.
One limitation of this method is that the cells can get distorted. Some degree of distortion of cells can occur with the concentration.
Not really so. It is more useful for paucicellular specimens like the urine and CS.
Yes, yes.
So very hypercellular specimens, you will have too many cells in this diameter. I can hear some noise, background noise. So too much concentration of cells in that small area, making it difficult to interpret the cytoplasmic and nuclear details. So as I said, it depends on the purpose of each department. Now, what is this? Somebody has to mute. I think I can hear some disturbance. Now, this is the liquid-based preparation. The sure path method and the thin prep method. This is the sure path automated station. This is the thin prep automated station. Here also you get a small diameter and concentration of cells onto the slide. And you can see the differences. We have worked with this on more than 1,000 specimens we have compared. And here you can see how the background is cleared off in the liquid-based preparation because of the pre-processing and clearing of all the proteinaceous material. So this also gives a very good cell concentration, but it has its own disadvantages. And then next comes the cell block. What are the different methods of cell block preparation, Shakti?
Ma'am, first fluid sedimentation.
Yes, you sediment. Then what do? The commonest is the plasma thrombin method.
Plasma thrombin method.
Yeah. So you add these two, allow it to, or then you can use melted agar and then refrigerate and make a cell block and process it just like, but you have to fix the fluid in formalin. And sometimes you can use tinted formalin to better identify, because the material that you are getting is very less in the whole thing. Now, once you have this fluid with you in your laboratory, when the slides are prepared or any preparation is prepared, what you are going to look at. First thing is whether you will see that it is adequate or not in terms of cellularity. Now, what are the expected cells in effusion fluid?
Mesothelial cells,
Yes,
histiocytes,
non-mesothelial cells. Now, in the mesothelial cells, you can have them as reactive mesothelial cells, or you can have them as,
neoplastic,
yes, I'm just clicking it for you. You can read it out.
and neoplastic, ma'am.
Yes, and then you have to decide on the basis of the quantity and quality of these cells whether there is a primary malignancy or a secondary malignancy. Then what are the other cells that you can get?
Hematopoietic cells, non-major cells.
Yes. Yeah, they are usually non-cohesive. Hematopoietic cells can be either reactive in the form of inflammatory cells, or you can have them in the form of neoplastic cells, as you get in different types of lymphomas. And in the major population, or the second or foreign population that you get in the non-mesothelial component is the neoplastic cells, which are mostly they are carcinomas, and they come as cohesive clusters. Sarcomas rarely metastasize to the body cavities, and melanoma also come as non-cohesive clusters, but carcinomas, they come as cohesive clusters. So here you have got 4 big clues over here. This is the second population. Again, everyone just have a look at this. Carcinomas, cohesive cells, sarcomas, they will be generally present as single cells, and in the form of spindle cells, they can come as clusters. We'll see in one of the cases. And then you can have the melanoma cells, which can be non-cohesive. Now, non-cohesiveness can also be a feature of carcinoma. Can it be a feature of carcinoma? Yes, Shakti?
Yes, can be.
Yes, ma'am.
Yes, the higher the grade of the tumor, the more the dissociation of cells, and then you can have a lot of dissociated and single cells and less cohesive cell walls. Now, the fourth approach is the ancillary testing or the immunocytochemical approach that we have. So in this, we have a whole list. You can do histochemical stains, like the simple stains that you have in your laboratory, PA stain, musicarmine, Alcian blue. That is what you can do in your lab. Every lab has that. So that's very useful. We will see how. Then you can do immunocytochemistry markers. They have just swiped the whole diagnosis of fluid cytology by the way of using cell blocks. Then you have flow cytometry, FISH for the lymphoreticular malignancies. Then you can do much more things with the fluid, because fluid is a very good medium of preservation of the cells. Why, Shakti? Tell me.
Ma'am, flow cytometry? What, ma'am?
Yeah, any advanced molecular studies, fluid is a very good medium. So why fluid is a good medium of preservation of cells?
Yeah.
The cells are multiplying in a natural environment. They are getting all the nutrients that they are requiring. So they are in their safe environment, very nutritious environment. They are healthy. And if you get such healthy cells for all your molecular analysis, it's just very easy to put it in the process of flow cytometry, FISH or NGS or any other molecular studies can be done very comfortably on these cells. As compared to FNAC, we can do a lot of molecular diagnosis on FNAC smears also. But when you are aspirating cells from a nodule or from a growth, you may hit blindly into necrotic areas. Then when you get necrotic cells, processing them through these, for these testing becomes difficult, and you do not get very good results as compared to fluid specimens, which are growing in a very natural and nutritional environment. Now, I had passed on to you to read the International System for Reporting Fluid Cytopathology. So this is what I wanted all of you to read. Just like we have the Milan system, we have the Paris system, Yokohama system for breast, And for different organs, we are coming out the Bethesda system for cervical cytology. So we have now a system that is the International System for Reporting Fluid Cytopathology. So today it will be a challenge for us to merge these categories with different entities that we are getting in the fluids, primary, secondary, as well as go on putting the cells that you are seeing into different categories. Shakti, why do we do this? Become stable. Why are you so uncomfortable? Become stable. Why do you need a reporting system at all for fluids?
Ma'am, for satisfactory non-diagnostic, for any negative for malignancy, any
So these
suspicious.
are the categories. But basically, why do you require any reporting system? We want common terminology to be used by all the pathologists.
Uniformity in the reporting. Basically,
yes,
uniformity in the reporting.
Yes, uniformity in the reporting. So my report can be interpreted in the same way as you are interpreting it, and we are not talking on different levels. So there is a uniformity and in communication amongst the pathologists as well as between the pathologist and the clinicians. And the second thing is that you are taking all the efforts to interpret your cells in such a manner that you can categorize them. Until and unless you take a lot of efforts, you do a lot of reading, you see more and more, you are not able to categorize those cells into one particular category. Sometimes you really become very vague, right from category 2 to category 5. You may not be sure. One cell looks atypical, the other looks malignant. So you have to sort of become very precise with your cytologic findings and narrow down to a category, and then in that category you have to give a recommendation. And the other important thing is that there is a meaning to all of these categories. There is an implication, that is each category has a significance of in the form of a ROM, that is a rate of malignancy in each of the category is also defined. So because of this requirement of different reporting system has come up in various systems. Just because people use their own terms, they make their own reports, very elaborate reports. Ultimately, it may not make any sense to the clinician or to your fellow pathologist. So in the fluid, you have these 5 categories. Can you now read each of them, Shakti?
Category 1 is non-diagnostic. Category 2 is negative for malignancy. And category 3 are ATP of undetermined significance. And category 4 are suspicious for malignancy. And last one, category 5 is malignancy.
So these guidelines have come by the International Association of Cytologists, but even the Indian Academy of Cytologists has at the same time had proposed this categories, and similar categories have been proposed by IAC also, and we were a part of this whole study. Now we have done an inter-observer agreement analysis using the categories of the IAC, that is Indian Academy of Cytology, for reporting serous effusions, and have come up with very nice results. Now, what is the implied risk of malignancy in each of these categories? I have already shown here. When you're saying non-diagnostic, yes, Shakti, you can read it.
This one 17%.
Of malignancy is around
17%. If it is negative, ma'am, it is 21%. If it is ATP of undetermined significance, it is 66% of malignancy. If it is suspicious, it is 82%. If it is malignant, 99%.
So each of the category tells you the risk of malignancy in that, and this is generally when we are using such classification, this is conveyed to the clinician also, so that helps them to interpret our reports better.
Yes, ma'am.
Now, how should be a sample report? I'm just showing you a prototype of the sample report which this classification tells us. So in any report, you have to mention the specimen type and from where it has been aspirated. So come on, Shakti, you can read it out.
First one is specimen type and location. Ascites is the space between abdomen. It is pleural. It is a collection of fluid in the pleural cavity, which is pericardial cavity, and any intraoperative peritoneal washings.
Yes, so we should know what is the type of specimen and from where the fluid has been sent. So generally they do write, but if we do not know, we need to find it out. What was the procedure done? If it is, what are the different procedures called in such patients?
In pleural effusion, there is abdominal paracentesis. Sorry, thoracentesis.
Abdominal paracentesis in pleural.
Ascitic. In effusion, there is diagnostic thoracocentesis. And in pericardial effusion, there is
pericardiocentesis.
Yes.
And if it is an intraoperative or a second look surgery, you have peritoneal washings. This is very important. You will understand why we should know from where the fluid is coming, because there are certain elements that also come along with it. Now you have to state the statement of adequacy has to be there, whether it is satisfactory for evaluation or not, that you have to mention. We will see what is that. And then if it is not satisfactory, you have to write why it is not satisfactory. Evaluation is limited by state whatever is the reason. There is too much of blood, there is thick proteinaceous material, the cells are degenerated. So you have to give the reasoning that the evaluation is limited by or unsatisfactory because of these factors. So let the clinician know very clearly that what are the limiting factors in your report, and that's why you're not able to give a report. And then you have to actually report the category. Now, what is it recommended? How you should put the category? I have striked out something over here. So 1, 2, 3 category, these you don't have to write. You have to write the content of the category. If one is non-diagnostic, write non-diagnostic. Just do not write the diagnostic category as Roman 1 or Roman 2 or Roman 3. So you write likewise non-diagnostic, negative for malignancy, AUS, or positive for malignancy. That is what this means. And then if you have any additional notes and comments, and if you have done some ancillary testing, you write all the details into your comments section. So this is just a sample report. So we will try to go to our
cases.
Any questions as far have we reached? Any questions anyone has?
No question in the chat box so far.
So this was just an overview of processing collection. Now we will go to our cases. Can I have Apurva Kale? She's there. Dr. Apurva Kale is there.
Apurva is not our students.
She wasn't our student, ma'am.
Okay. Then we have Fatima from NKP Salve.
Yes, ma'am. Good evening, ma'am.
Yeah, good evening. Now you have seen these slides. What are you seeing here?
Ma'am, in this smears, I can see the some smaller sheets of mesothelial cells, which shows the windowing effect.
Just read the history to me.
Sorry. 36 years female, abdominal distension, USG shows cystic pelvic mass 10 by 12 centimeter.
Okay. So this is a ascitic fluid that has been sent to the laboratory. What are you seeing in the smears?
Ma'am, in the smears, I can see the mesothelial cells showing the windowing effect. Some reactive mesothelial cells can also be seen with the binucleation, and background shows proteinaceous material. Some
No,
lymphocytes can be seen,
okay.
and
These are the
macrophages can also be seen, ma'am.
These are the macrophages with engulfed material, and these are the mesothelial cells. Now, how have you identified these cells as of mesothelial origin?
Ma'am, they are round cells with a round nucleus which is eccentric in position, and a cytoplasmic border is sharp.
What else?
Prominent nucleoli.
Let me zoom it out. Okay, yes, everyone can see the prominent nucleolus in this. Here also you can see. What else you can see in this?
Cytoplasmic vascularization.
And windowing effect can be seen.
Window, what is that effect?
It is due to the microvilli which are present in the wall.
Wall? Wall of what?
Ma'am, microvilli present in the cell membrane.
Surface. On the surface of the cell, you have plenty microvilli that separates the cells and gives a window effect in between the cells. So this is very clearly seen over here. What else you are seeing?
Ma'am,
What
there
is
is, ma'am, cytoplasm is a dual color, like outer somewhat dark and inner pale.
I can see the other way around. Here it is paler, and here in the center it is looking more dense. Why does that happen? Why does that happen? You get a very freely cytoplasm to the mesothelial cells. Normally they have a very freely cytoplasm. And why does that happen? It's because of accumulation of, try to see if we have accumulation of fine vacuoles. Now what is this you are seeing over here? Pardon?
It is mesothelial cell.
Yes, it is a mesothelial cells, of course. It's binucleate or I think multinucleated, and plenty binucleate cells are seen all over. And then you have these pattern, this pattern, dual pattern or accumulation of 3 cells together or 2 cells together is a very common pattern that you see. What is that? Because of here you can have a trail of cells over here. Why do you get this pattern?
This is cell cannibalism, ma'am.
No, there is no cannibalism in this. They are just 2 cells adjacent to each other. Here again you can see over here. So this dual arrangement of the cell is very typical, or if this is extended more, it can be in the form of a trail of cells. You can have 3 cells, 4 cells, and sometimes you can have long trails present. But why does this phenomena happen? It's the normal histology of the mesothelium. There is a single layer of mesothelial lining cells, and then beneath it you get the sub epithelial connective tissue which is present. So they start exfoliating in the same manner when they are not very hyperplastic or hypertrophic. Now, do you feel that these cells are very hyperplastic or hypertrophic, or they are just very cool and normal looking? Are they of normal size and shape?
No, ma'am, my slight hyperplasia.
Yes, there is slight amount of hyperplasia because there is increase in the number of cells. So what is the normal number of cells that you can get in fluids? Is there any normal number or a cutoff for a normal number of cells that tells you that this is an adequate cellularity?
No, ma'am, I think.
So there is no cutoff for a normal number of cells. You can get as few as 5 to 10 cells, or you can get as many as these cells depending on the situation of the lining mesothelium and what it is undergoing, the irritation that it is undergoing because of the accumulation of the fluid. Now, is there something missing depending on the history of the patient? You have a cystic pelvic mass.
Yes, ma'am.
Abdominal distension. So, are you expecting anything in this? Were you expecting some malignant cells in this?
Yes, ma'am, but we can't see any malignant cell as such.
So, you are not seeing any malignant cells. But can that happen?
Yeah, ma'am, it can happen because cystic pelvic mass is quite large. Dimensions are very large.
Yeah. And if that happens, does the sample become non-diagnostic? Because the clinician has sent you for a huge pelvic mass thinking that it is, and the radiological findings are of a huge abdominal tumor, benign, query malignant. And if you're not reporting any malignant cells, does that sample becomes non-diagnostic?
No, ma'am.
Why? What are the reasons of non-representation of the malignant cells in a ascitic fluid or massive ascites with a cystic pelvic mass? Okay, we'll see that a little later. Now, what is this?
Sheets of round to polygonal cells with angulated cytoplasm and monomorphic sheet it is, ma'am.
Yes, it is a very flat monomorphic mosaic type of sheet of mesothelial cells. How do you think this has exfoliated or have we aspirated it? What are the different methods by which it comes into the fluid?
Might be aspirated because
Yes.
it is intraoperative fluid.
When you're putting the needle into the abdomen to collect fluid, you may traumatize the mesothelium and you can bring out such sheets of cells as against to those that are exfoliated. But sometimes you can even get such sheets of cells, hyperplastic cells that are exfoliated on their own. Now, what are you seeing here? Again, this is which stain?
Pap stain.
Oh, no.
So,
This is the MGG stain.
Giemsa stain, yes, ma'am.
So we do HNE, PAP and Giemsa stain. Make Grunwald Giemsa, that is what we do in our department. So what are you seeing over here? Again
the ma'am sheets of mesothelial cells which are round with round nucleus, eccentric round nucleus and moderate to scanty cytoplasm.
But can you see something over here?
Yes.
What would you call this? There is some nuclear enlargement.
Yes.
So nucleosis is there.
Yeah, the nucleus looks little large, NC ratio looks little higher, but here you can see these window effects, and otherwise the sheet is very classical with the mosaic type of arrangement. Now, what are these cells over here?
Macrophages.
Yes, they are all macrophages. So the second most component of any fluid cytology are the macrophages, which can resemble mesothelial cells a number of times and cause diagnostic problems. Now, any difference in this cell? What are you seeing surrounding in the cytoplasmic membrane?
Blebs can be seen.
Blebs.
Yeah, you are seeing blebs. Now, what are these blebs? And how are they different from microvilli? Blebs is nothing but a degenerative change in the cytoplasm. Microvilli, they are a component of the cytoplasmic membrane and they are pretty long in hyperplastic and hypertrophic cells. And now here you can see little amount of pale cytoplasm, but at the periphery it is denser. And here you can see the nucleus is just trying to touch the cytoplasmic membrane, but in this dimension, I'm unable to demonstrate that there is a space. Now, in these histiocytes, you're seeing these. What are these inside the histiocyte?
Maculated cytoplasm. Or
yes, and engulfed nuclear debris. Here you can see a very nice foamy cytoplasm. Now, what are these cells? Again, very easy to diagnose.
Sheets of mesothelial cells which are enlarged and with eccentric nucleus. And
Eccentric or centric? Okay.
Yes,
Paler cytoplasm, all the features of mesothelial cells, blebs, microvilli, two-tone cytoplasm, windows in between the cells, and a slightly clasping type of arrangement, which we will see better in the coming pictures. And here you can see the binucleation. So you are seeing all these. These pictures are all from my own collection. Sorry. So what do you think? Is this an increased NC ratio? Are these normal cells or are they atypical?
Oh, typical, ma'am.
Why? What has happened to this nucleus? It is jutting onto the cytoplasmic membrane. Pardon?
Yes, ma'am. It is touching the cytoplasmic this wall.
Yeah, but we are. Have I zoomed it enough? Let's see. It's almost touching the cytoplasmic membrane. So, would you like to call all these cells as atypical? You are not seeing any nucleoli, or they are just reactive mesothelial cells.
Mild atypia can be seen.
So there is some, you feel that there is some mild atypia in this. Now here are some more examples of all the mesothelial cells. Now single cells we have talked about. You can see the nucleoli, and they can be single or they can be multiple. They are of varying sizes. That is what you are seeing. Then you can have this assigner arrangement. You can have this. What is this looking like? What are you seeing this?
Morules.
Are they giant cells? Can you get giant cells with the mesothelial cells? Giant cells are common with reactive mesothelial cells. You are seeing these nucleoli very nicely in all of these cells. And you have some collagenous material inside. And this, I think this picture alone I have taken from the TIS classification book. They have given the variety of normal mesothelial cells that you can get. And there is an admixture of lymphocytes and polymorphs basically.
Polymorphs are there.
Yeah, and there are a lot of giant cells in this specimen. Now here is a histologic correlate of the same. When you have this micropapillary hyperplasia of the mesothelium, this is what you get. You get a central core, you get this collagenous material, and then which is capped by these reactive mesothelial cells. Here you can see those binucleate cells. See, you can have all these variety of cells and you are just getting a replica in the cytology smears. Now, what are you seeing over here? Something I've pointed out. Yes, Fatima? Yes? There is a vacuole, very nice, well-defined vacuole pushing this cell and making it a signet ring type of cell because the nucleus is pushed to the periphery. Here you have multinucleation, you have a single and multiple nucleoli inside the nuclei. We can appreciate the fuzzy margins of the mesothelial cells, giant cell formation. Here you have very reactive nuclear enlargement, macronucleolus. So do you think that these are all normal mesothelial cells or are they atypical or are they malignant?
Normal mesothelial cells.
So you feel that this is a spectrum of normal mesothelial cells.
I'm not
So
all like some shows atypia, ma'am.
So you feel that there is some amount of atypia. Not atypia can occur because of chronic irritation of the mesothelial lining?
Yes, ma'am.
And why this vacuole has come over here? Does it indicate any neoplasia?
No.
There is a vacuole. Here also there is a vacuole. So there can be, the cells can imbibe the fluid and create vacuoles. And but see, the nuclear quality is similar to the nuclear quality of the rest of the reactive mesothelial cells. So this is just a normal phenomena that you can get with the reactive mesothelial cells. So when you're looking at these cells, you have to see their architectural nature, whether they are coming in cell balls, giant cells, single cells, cells as pairs or in triplets or duplets. And then you have to look at the nuclear features and see the cytoplasmic features. So I think this is just a spectrum that you are seeing. Just a minute. So I had asked in this, what is your interpretation? So Fatima, what did you interpret it as?
Category 2 negative for malignancy.
It wasn't non-diagnostic?
No, ma'am, because there was quite a good cellular smears.
Yeah, so no representation of malignant cells in a specimen from a patient suspected to have malignancy does not mean that it is non-diagnostic. So if you have good amount of cells, they are well preserved, well processed, and they are well displayed. You can see all the morphological features. So it becomes a reportable specimen. So then in those terms, which is a truly non-diagnostic specimen? When will you call it non-diagnostic?
Ma'am, when the cellularity is low and the cells are not preserved properly, or where the cellular architecture is limited by some mucoid material or hemorrhagic aspirate, then it can be non-diagnostic.
Basically, when it is pre-analytic, when the preservation of the specimen is not good, right from the ward, they have kept the specimen out for a very long time. How much time can you keep the specimen outside the refrigerator so that the cells are well preserved? The optimum time from the time the fluid is removed to the time it is received and processed in the laboratory, which is the optimum time to give you a good cell morphology?
And 4 to 6 hours?
No, that's quite a big. We ideally say half an hour, but a maximum of 1 hour is just okay for the cells. Otherwise, if you are expecting delay, you have to keep it in the refrigerator, and then you can preserve the specimen and the cells for 4 hours, 6 hours, 8 hours, even 24 hours and 48 hours. Okay, but if it is lying, yes, sir.
Ma'am, actually it depends upon the climate also. In the older
Yes,
climate,
exactly.
it can remain in the container for a longer period of time. In hot and humid, the cells will degenerate very fast.
Yes, exactly. I was to come to that point. So depend, if it is very hot, the cells will degenerate faster. So you have to take enough care, and even sometimes it is recommended that you maintain a cold chain in the summer season. You carry it in an ice box so that the cells do not degenerate or the cells do not lyse. So only a specimen which are showing degenerated cells, lot of proteinaceous material, have I put it? So we have talked about it, negative for malignancy. So in this, we have covered two categories, that is the non-diagnostic category, and this case that we saw was of negative for malignancy. Dr. Bharadwaj or Madam, you want to make some comments? So
Yes,
that.
This is for the student. Sometimes we get two negative results from the cytological examination of the aspirated fluid, though there is some lesion inside. So it is due to, what are the most common causes of this true negative results? First, it is due to blockade of lymphatic by the neoplastic cells. We may not get these neoplastic cells in our examination, or increased capillary permeability due to various chemical mediators that are released by the pregnant cell, or due to the coverage of the lymphatics by the thick layer of fibrin that covers the serosal surface and of the pleural cavity, or in case of low grade tumor, or in case of fibrosis due to radiation, we get these true negative results due to all these conditions. This much I have to
Yeah,
tell.
that's very much required, very perfect, and apt points that needed to be highlighted. Now, in the same chain of, yes, sir?
Sorry, another point which I wanted to add was that many a times, if the effusion has been there for a longer period of time, you will get a lot of degenerated cells. So you might have to ask the clinicians, please submit a fresh specimen.
Yeah, we'll come to that also, and how we have to request for that. Now, in this same chain, I want you to interpret this. Who will do this for me? Purtika, we have Punika.
Yes, ma'am.
Where are
Ma'am,
you?
I'm here. Ma'am, am I audible, ma'am?
Yes, you are audible.
You are.
55 years old male, chronic alcoholic, presented with ascites.
Okay, so we have got ascitic fluid.
Yes, ma'am. Ma'am, I can see the cells which are present in clusters or in sheets which are round to oval with prominent nucleoli and scant eosinophilic cytoplasm. And also in the background, I can see some inflammatory infiltrates and proteinaceous background.
Okay, you were talking about this HNE smear?
Yes, ma'am.
You said that there is scant cytoplasm. I see scant cytoplasm only in an occasional cell like this one. Otherwise, there is moderate amount of cytoplasm in all of these cells. What is the other feature? There is variation in size of the nucleus. So there is anisonucleosis. You said that you saw some nucleoli, prominent nucleoli.
Yes, ma'am.
Yes. So we come closer to these cells, and you are having a higher NC ratio, and some nuclear atypia is there. And now, what is this thing you are seeing over here? What is this phenomena called?
Ma'am, is that the windowing effect or?
Yes, there is a window effect, but doesn't it seem that this cell is clasping the other cell? So it's trying to hold it like that, and this is called a clasping type of effect. And again, you can see a chain of cells over here. Here you have a large nucleus, and then these prominent nuclei, some inflammatory cells. Now here, what are you seeing in this picture?
Ma'am, in this picture also I can see the cells which are arranged next to one another, and also there is pleomorphism of the cells. The varying sizes of the cell nucleus can be noted, and also this multinucleations can be seen, ma'am, with
So
the
here
prominent.
there is anisocytosis, that is variation in size of the cell. Then there is anisonucleosis also. And what is this at the arrow?
Ma'am, that is the multinucleation.
Yes, and this nucleus is large. What is the normal size of the mesothelial cell? A medium-sized mesothelial cell. What is the ideal size? And what is the range of the size of mesothelial cells?
Ma'am, is it 30 to 75?
The range can be as small as this cell, 9 to 10 micron millimeter in diameter, to very large cells up to 60, 50 micron millimeter in diameter. So you can get a huge range in variation in the size of the cells in the reactive mesothelium or hyperplastic or hypertrophic mesothelium. So, and along with that, there is still maintenance of the NC ratio. Although the size increase, the size of the cell is increased along with the size of the nucleus. So here you can see variation in size of the cells, variation in the nucleus of the cells. So what do you think these cells are?
Ma'am, can it be reactive mesothelial cells?
You still feel that these are reactive mesothelial cells. You don't find
Ma'am,
any atypia?
Ma'am, it is there, but ma'am, in case of reactive mesothelial cells, also there can be variation in sizes.
Yes, very true. They can show marked variation in size. What is more important, the nuclear membranes are very smooth. There is no irregularity of the nucleus membrane. They are still showing the fuzzy margins. They are showing the windowing effect. And here you can see the LC ratio is still maintained. It's not very bad. We know that there is multinucleation and hyperchromasia in reactive mesothelial cells. So you thought that there was some atypia over here. Is there any difference between the appearance of cells in both these pictures? These look a little more bad than these, or both are same?
Ma'am, almost the same.
Yes, so they both are same. There is some amount of atypia. Now, would you like to put this atypia as favoring malignancy or favoring a reactive process?
Ma'am, I would like to put it under favoring a reactive process.
Yes. So that is one thing. Now, another picture over here, you are seeing some more, this rosetoid arrangement.
Yes, ma'am.
Here you're getting the cells in as, describe this.
Ma'am, the cells are arranged in the rosette pattern or in the clusters, which are hyperchromatic with a hyperchromatic nucleus and scan to moderate amount of cytoplasm. Ma'am, also I can see one vacuolated cells is also seen,
and these clusters, they are having a classy knobby end.
Yes,
they are having knobby margins. And here you can see a huge cluster of hyperplastic cells, and again some more cells you are having over here. So do you feel that they are atypical? Or they are normal looking? So in which category would you like to put them? Now this cluster again, very clear. Yes, describe.
Ma'am, this is the cells which are arranged in clusters with the nucleus.
Each nucleus is showing a very prominent nucleolus.
Prominent nucleoli and ma'am, scant amount of cytoplasm.
So do you feel that this belongs to the family of mesothelial cells? The cells that we have been seeing before in the past pictures? Are these mesothelial cells or they are some alien cells? Start looking for the morphological features, the margins, the windows, the clasping effect, the nucleoli.
Ma'am, I think it is I think it is still the reactive mesothelial cells, ma'am.
Yes, so these are still reactive mesothelial cell, although the previous one, they were looking a little atypical. Now, when you have such a doubt whether these are reactive mesothelial cells or they are atypical cells of undetermined significance. Now, this is the third category that you have in the TIS classification. You have read about it?
Yes, ma'am.
Yes. So if you want to put these cells as atypical cells of undetermined significance, you are not sure that they are favoring malignancy or they are favoring a reactive process. You are in doubt that these are atypical cells, then you have to, how would you like to confirm this whole thing? How would you like to go?
Ma'am, the first thing is I would see whether that if there is any small number of atypical cells, and if I'm giving it as the atypical cells of undetermined significance, I would go for immunocytochemistry. I would look for either whether that is the macrophage or the mesothelial cells, and if it is macrophage or mesothelial cells, then I would like to categorize under this negative the demonstration of epithelial origin, then I would like to go for suspicious for malignancy. And if it is
no, right now you want to put this as AUS. You want to put this in the AUS category, isn't it? You found that these cells were atypical.
Yes,
and the third category we have is the ATP of under. What are the criteria of this? Just read this out.
Ma'am, mild in category 3, ATP of undetermined significance, mild to moderate nuclear enlargement with slightly increased nuclear to cytoplasmic ratio, prominent nucleoli, slight nuclear membrane irregularities, altered chromatin, and altered cytoplasm.
Okay, so except for this membrane irregularity, we saw most of the features. Now,
yes,
what is the difference between, you didn't want to call them suspicious for malignant cells. Did you want to call it suspicious?
No, ma'am.
You wanted to call it ATP of undetermined significance. So whenever you are calling the cells as AUS, you are putting across that these cells are favoring more of a reactive process rather than a suspicious for malignancy process, because the risk of malignancy in the AUS is slightly higher than in the negative sample, and it is much higher in the suspicious for malignancy category. So you have to be very clear. This is the importance of putting the cells precisely into the category so that the clinician can understand that you are dealing with a lower risk of malignancy as compared to suspicious for malignancy. Now here, what have we learned with all the pictures that we saw? That the reactive mesothelial, yes?
Ma'am, the reactive mesothelial cells, there can be morphological overlapping with the malignant cells, and the cells in the fluid medium can round up because of also because it can continue dividing, so there can be proliferation spheres. And except for the high-grade neoplasm with the pleomorphic cells, standard cytological criteria of malignancy, single-cell morphology are not applicable. The native shapes of the cancer cells cannot be a guiding feature for deciding the primary origin of malignant cells.
Yes, so when we in cytology, we decide malignancy on the basis of finally sheets, clusters, shape, size, everything is there. But when you have to call it malignant, the single dissociated cells should show all the features of malignancy of high NC ratio, hyperchromasia, irregularity of the nuclear membrane. So these standard criteria of malignancy do not apply to cells in the fluid. That is one thing, because the cells, they are lying in the fluid for a long time, and because fluid is a very nice medium for them to grow, they just round up in balls because of the surface tension, and then the standard criteria of malignancy cannot be applied to these cells. So this is, and as we said, that the reactive mesothelial cells, they will have many faces. Some are very quiet, cool, and some are very bad, which are frightening, and therefore we have to be very cautious when we have to deal with such cells. Dr. Bharadwaj, any comment?
Ma'am, I'm also for reactive mesothelial cells only with mild atypia. I don't think they are really malignant cells.
Yeah. So still, if you are in doubt, because this is immunocytochemistry is very easily available in every department these days. So such cells you can
make a cell block. We can go for a cell block.
Yeah, and then do calretinine. So calretinine will be positive in the reactive mesothelial cells, but you have to supplement it with epithelial membrane antigen, which will be negative because they are mesothelial cells and they are not epithelial cells. And one very good helpful stain is the desmin, which is positive in reactive mesothelial cells. That comes to our rescue many a times when we are having serious doubts about this. So all the residents who are present here, you have to remember this triad of immunocytochemistry. But along with this, we do also have histochemistry with us. But here we did not have any doubt about these cells being atypical adenocarcinoma cells. We were still in the zone of atypical mesothelial cells, so we'll deal with that a little later. Now, this cluster, what would you like to call it? AUS or suspicious for malignancy?
Ma'am, can I go for suspicious for malignancy?
Yes, so I've just kept this slide to show you a more degree of atypia in all these cells. Is this disturbing? More degree of atypia in all these cells, but ultimately these cells again turned out to be reactive mesothelial cells. If you zoom in and see these cells, they still have all the features of reactive mesothelial cells. But they do create sometimes doubt of suspicious for malignancy, but we have to be very clear because AUS has different connotation and this has different connotation. Sorry.
Well presented slide, madam. Nothing more to add. Very nice slide and present.
Yeah. Now another this difficulty arises when the cells are very degenerated. They become bloated, then they become large. And here, like you are seeing in this, you get a lot of vacuoles in the cytoplasm. So they start resembling adenocarcinoma cells. So what do we call this? Now this was from a patient known case of CA breast. These are all degenerative vacuolation that you are seeing, and they are all probably mesothelial cells because you can see the family of the cells to which they belong. They belong to their progeny. They resemble their family of cells with these windows, polygonality, clasping effect, and the nature of the cytoplasm. So from this, you can say these cells are just degenerating cells, and this is known as WAD, worrisome atypia related to degeneration. So this is very commonly seen in the smears. Now just summarize this AUS versus SFM.
Ma'am, in case of AUS, the cytological features, only mild cytological abnormality can be seen, whereas in SFM, greater degree of cytological abnormalities. When we come to the cell lineage, benign cell type favored, but benign or low-grade tumor cell of origin not excluded. But when coming to the suspicious for malignancy, epithelial or other malignant cell of origin strongly favored. And in immunochemistry, outcomes may be benign in case of AUS, SFM, malignant or inconclusive. And in case of SFM, outcomes usually are malignant or inconclusive. When suggested risk of malignancy in AUS, it is 20%, whereas in case of SFM, it is 80%.
Okay, so I think we can, reporting will just can I have Saudamini?
Yes, ma'am.
It's already 8:30. I think it will be a little difficult for me because we are still at the second case. Can you describe this slide? Saudamini?
Yes, ma'am.
Yes, what are you seeing here?
Ma'am, this looks like a this shows high cellularity in the slide and looks like there is some
Depends upon
hemorrhagic.
the stain, which stain it is.
So is
This
this
is the stain.
MGG stain?
Yes, and this one?
Ma'am, this is PAP.
Yes. What are these cells?
Ma'am, looks like a group of overlapping cells with moderate amount of cytoplasm. Nuclei are overlapping. So these could be mesothelial cells with overlapping nuclei.
Now
Or
we
they
saw
could
two
be
big mesothelial cells. That's why I took up the case of reactive mesothelial cells in great details for you to make an impression how the benign cells look like. Now these are histiocytic cells.
histiocyte.
And
Yes, ma'am. These could be histiocytes also.
histiocytic here you are seeing more foamy pale cytoplasm. They are overlapping, and most of the nuclei, they are not round or centrally located. They are elongated. Or at least, yes. So this is what you are seeing here. Now some more cells. And here, what are you seeing again? Foamy cells.
These are foamy collection of foamy cells with foamy vacuolated foamy cytoplasm. This is an irregular cluster, and
So cytoplasm is definitely not dense the way you saw in the previous cases.
the cytoplasm looks more foamy and paler in appearance.
Yes. What is this configuration?
This looks like a irregular kind of a cluster. Could be a granulomatous kind
It's like
of.
a granulomatous arrangement. It's like a granuloma that you are seeing. Here
Yes,
you are
ma'am.
seeing. Yes, and here you are seeing some
Giant
cell
cells. Yes.
Now here you can see these cells better.
Yes, ma'am.
Now in fluid cytology, when you get granulomas, can you get tuberculous peritonitis, ascites because of tuberculosis?
Yes, ma'am.
That's very common. So I will be very fast and will be straightforward. Now here these are epithelioid cells.
Yes, ma'am.
See, when we say epithelial-like histiocytes, they are epithelioid cells. And classical epithelioid cells that you find in FNAC smears, they have a slipper-shaped nucleus. I've put it in the inset. And here you are seeing these epithelioid cell clusters. Now, any other cells you are able to see? What is this background that you are seeing over here?
Ma'am, this looks like a necrotic debris.
Necrotic, not dirty exactly, fatty, cheesy,
Yes,
and
ma'am.
necrotic background. What is this?
Ma'am, these look like inflammatory cells.
Which?
Ma'am, this predominantly looks like lymphocytes.
Yes, so this is an aggregate of matured lymphocytes which is seen. So all these components, one by one, if you all put together, something is missing in all these slides. Even the previous one, the background is pretty clean. There is some amount of blood and some necrosis, but then there are no mesothelial cells.
Yes, ma'am.
So what does just now Dr. Subhash, sorry, Madam told us that you don't get mesothelial cells sometimes. Why don't you get mesothelial cells in tuberculosis? Anyone?
Ma'am, because there will be fibrosis.
Not exactly fibrosis. There is a lot of fibrinous material which is being secreted, and that makes a coating on the lining of the mesothelial cells and inhibits them from exfoliating into the fluid. That is the reason. And then clumping of these lymphocytes also favors benignity. So you may have serious doubts regarding those histiocytes, but because of clumping, that favors the benign process. And here this is the AFB positivity, and this is the cell block. Now in this cell block of one of our patients, it was not very easy to diagnose tuberculosis in this case. Rather, the diagnosis was more easy with those epithelioid clusters that you saw. Yes. So always the cell block may not be very rewarding. That's what I want to project. Here you do have a granulomatous type of arrangement, but the epithelioid cells that we expect normally, that slipper-shaped nuclei, etc., may not be seen. And a very good AFB positivity. Yeah. Now, when all do you see a lymphocyte? We'll just extend this case to another condition. T cells, they predominate in reactive processes in 80% of the cases. Patients with tuberculosis will present with effusion composed predominantly of T cells. Now, the differentiation of a reactive lymphoid proliferation versus lymphoma may sometimes be difficult. Now, here you can see a reactive population of lymphoid cells. Yes. This is a little large. This is another cell, and then you have the mature lymphocytes. Here you have a uniform spread of monotonous population. Here again, you are seeing a monotonous population, but then here you can see some mitotic figures as well. Yes, ma'am. So what do you think that this could be?
Ma'am, this could be a lymphoproliferative process with the because of the presence of these mitotic figures, especially atypical mitotic figures, multipolar atypical mitosis.
Proliferative process. So when a smear is dominated by lymphoid cells, you have to be very critical. Are they mature? Are they clumped? If they are clumped, that is favoring benignity. If they are reactive, are they truly reactive, or they are a part of a reactive process? Or is there any monotony of the cells? And if there is monotony, how atypical these cells are? So what would you start thinking of? Here again, you are seeing these atypical cells. So are you thinking of a lymphoreticular process? Do you think that this could be a lymphoreticular malignancy? Now leave apart that tuberculous patient. That's over. But you can see a lymphocyte, a lymphoid population predominant smear.
Yes, ma'am.
Yeah. So you have these atypical cells and something in the background, very dirty background.
Yes, ma'am. Necrotic type of
Yes.
background, dirty
What I want to
background.
highlight here is a necrosis favors lymphomas versus adenocarcinoma. Now, high-grade adenocarcinomas can also have dissociated cells, but necrosis is very unusual to get in fluids as against lymphomas. Yes. Again, here you are seeing a monotony of cells.
Yes, ma'am.
Yes, and there are some, of course, there are some large and some small cells, atypical lymphoid cells. Here, MGG stain smear is very beautiful over here. You have these monotonous large.
Population.
So what would you suspect in such cases?
Ma'am,
Lymphoma?
lymphoma could be could be the primary differential.
Now, when we were talking about wet films, if you see such a monotonous population and you have the feeling of lymphoreticular malignancy, then you can keep some amount of the sample for flow cytometric immunophenotype. So that is the significance of rapid assessment of any wet fluid you have. Now, what are all these?
These look like degenerated cells.
We call them smudge cells. So this is one of the basic learnings. Yeah, we do. These are the preserved cells. These are the smudge cells. And the higher the grade of the malignancy, the large cell lymphomas, they will have more number of smudge cells and there will be more degeneration, more necrosis. So you have this necrosis in large cell lymphomas. Now, these days, the beauty of flow cytometry is that you can diagnose all lymphoreticular malignancy. Now, this is one of our patients with pleural fluid cytology showing predominantly degenerated, few atypical mononuclear cells with cytoplasmic vacuoles. Here you can see these cytoplasmic vacuoles.
Yes, ma'am.
Yeah, in this pleural fluid cytology was done. He was a 12-year-old boy with mediastinal mass and pleural effusion dyspnea at rest, and nothing could be done in him. You couldn't take a biopsy, you couldn't do a bone marrow aspiration, bone marrow biopsy. So we received his fluid and flow cytometry was done. All myeloid T cell and NK cell markers were negative. This case has been contributed to me by one of my colleagues, Dr. Purnima Kodate. She's a very good flow cytometric faculty. And then they finally use this fluid for even molecular testing for CMYC. And then it turned out to be a Burkitt's lymphoma. All these markers were positive on IHC, on cell block, and IHC on the cell block, as well as there was concordance with the FCI findings, and it turned out to be a Burkitt's lymphoma. So the point that I wanted to bring out in this case was that a lymphoid population of cells dominating in the fluid, you start thinking of different possibilities. And if you're serious about lymphoreticular malignancy, you have this option of doing molecular analysis in the form of flow cytometry or immunocytochemistry on the cell. Now, I think we move to the next case.
Another one important thing, madam, primary effusion lymphoma, the students should always know about this. It is a rare type of lymphoma. It is associated with the HHV8.
Yeah.
Usually, this type of effusion we get in HIV positive cases.
Yes, that's very true. And by and large, leaving apart this primary pleural effusion, lymphomas, lymphoma is generally, or leukemia, they are generally diagnosed previously clinically. So it's not a very difficult diagnosis when you start getting these mononuclear cells.
Yes, ma'am.
So, yeah. Now coming to case 3, can I have Dr. Poonam with me? No, not Dr. Poonam. Sorry. Who do we have? Dr. Das?
Dr. Salman.
Salman.
Yes, ma'am.
Okay. Salman, please come. Can you describe this?
It's a case of a 52-year-old female which presented with shortness of breath and with increased abdominal distension for last 3 months. And on operation, we got a right pelvic mass 1 year back, which was operated before. And now paracentesis has been done and 1500 ml thick mucoid fluid has been aspirated.
Yes. What are you seeing in these smears?
Ma'am, in the first slide, as you can see that there is this cluster of cells which hyperchromatic nuclei with knobbly edges and
And let me tell you that this is a LBC smear, sure path.
yes, ma'am.
So what are you seeing? Small dark clusters. You can hardly see the individual configuration, but then here you can see some trail of cells. Like I told you, you can get in normal mesothelial cells.
Yes, ma'am.
Yes, but these are very pretty dark. Here you are getting a binucleated mesothelial cells. So there is an admixture. This is a very large cell with a small baby cell attached to it and a small window over here.
Yes, ma'am.
What is this? And some thick strands over here in between the cells connecting them.
Background. I think this.
Yes, these could be mucoid, thick mucoid strings that are connecting the cells. Now in this H&E stained smear,
Ma'am, here it's an adequate smear, ma'am, which shows cells with I can see, ma'am, some vacuolation, cytoplasmic vacuolation, and the cells have mild pleomorphism, mild to moderate pleomorphism.
if you are taking this as vacuolation, let's zoom and see what it is like. Is it really vacuolation? No. So none of the cell is showing any vacuolation. So you are seeing only nuclei, small nucleoli, and all of them are trapped in the thick mucoid material. So are you being able to form any opinion whether they are benign or malignant on this?
Ma'am, I think they are malignant.
You feel that they are malignant. Low-grade malignancy, borderline malignancy?
Low-grade malignancy.
Low-grade malignancy. You're sure about it. Okay. Now in this, some more fields of the same case.
And here also we can see the thick mucoid background.
Yes. So they are entrapped in it. But you're not able to see any morphology. Sorry, this is a repeat picture. So what would you like to call it?
Ma'am, can it be, ma'am, ma'am, pseudomyxoma peritoni?
Yes, the history is telling you that very clearly, and even the cytological picture where you are getting this thick mucoid material and with these low-grade cells, only the details of these cells are visible. Like in this picture, you have these rolled edges of these cell clusters, and then here again you have very thick clusters, and you have these high NC ratio cells with vacuolation of the cytoplasm. Sorry, I can't see this. Here again, you have some cell balls and cell clusters, but the nuclear details are not seen. Now, you cannot be very sure of malignancy in this. Dr. Bhardwaj, what do you say?
Now I'll give it as strongly suspicious for malignancy.
Yes, so it favors suspicious for malignancy, and it has been made very clear that when you have only mucoid material, that also cannot be given as positive. Or if you have mucoid material with such entrapped benign to slightly atypical cells, you still have the category of suspicious for malignancy, which is the category 4 of the TIS classification. And if you are very confident that you can call it suspicious for malignancy or maybe malignant, then it really requires good confidence in the morphological interpretation plus ancillary testing and the availability of the clinical data. That's also very important, radiological findings. And of course, the experience of the reporting pathologist is very important because there will be a therapeutic implications to your report. It will be very important that whether something which you give is not positive, false positive will have a wrong implication in the clinical management.
Yeah.
So, Salman, can you read us out the criteria?
The cytologic criteria for suspicious for malignancy are cells should be present in small or occasionally in large numbers, but they are limited by either artifacts, preparation, or staining, or proteins, or necrosis.
So we'll just stop here. I've just put up a picture. Here you still have cells, but they are entrapped in necrotic material. You cannot see the nuclear details. They are degenerating. But here and there you find that one odd cell is having a high NC ratio, hyperchromatic nucleus, a papilla type of arrangement. So you can then, this first point favors that you can put it as suspicious for malignancy. Second situation scenario would be?
Ma'am, there are monomorphic lymphocytic population or atypical lymphoid cells, which can lead to suspicious for lymphoma.
Yes.
And presence of presence of mucinous material alone or with small numbers of bland epithelial cells that favors a diagnosis of pseudomyxoma peritoni. Requiring confirmation of malignancy and of the primary site is needed. And mesothelial proliferation is suspicious for mesothelioma. So malignant is the primary one.
So under the category of suspicious for malignancy, you have three situations: epithelial, metastatic, lymphoid, and the primary malignancy. All of these three have their own suspicious cells. If you have atypical lymphoid cells, you can put it as suspicious for lymphoma. If you have epithelial cells, you can put it for suspicious for metastasis. And if you have atypical mesothelial cells, then you can call it suspicious for mesothelioma. So they have designed this category, and when you say that it is suspicious for malignancy, the chances are high that it will turn out to be malignant in 80% of the cases. Now, another important feature is that the suspicion, finally, when you will put it as suspicious for malignancy, it will be after all your ancillary testing. It will not be a primary report. Your report goes in two tiers. If you have read the TIS classification, you can let go of the first report where you are suspecting malignancy, but then write in the notes that I'm processing on this, I'm doing these special stains, I'm doing this cell block and putting the markers. And then when the results have come, you frame your report once again, and depending on whatever the findings of your ancillary test, you finally put it as whether it is suspicious for malignancy or it has become negative for malignancy, which has turned out to be a positive for malignancy. So this category, this SFM will come only after your ancillary testing has been done with full confidence. Now just extending this case to more positive cells. Now we know that metastatic malignancy is the commonest malignancy in the fluids. 80% of the time the fluids will show these metastasis, and commonly, which is the common carcinoma that is coming? Adenocarcinomas are very common. Do squamous cell carcinoma come in the fluid very often?
No.
Sarcomas? No. Sarcomas also, only 5% sarcomas will metastasize. So the commonest is the epithelial malignancy. Most commonly is the mucin secreting malignancy. And what are the different organs? If it is a pleural fluid, which is the commonest site?
Ovary.
Pleural fluid.
Pleural.
Breast, lung. First comes the lung, then comes the breast.
Breast in females.
Get the prostate, because prostate metastasizes very commonly to the lungs. If you have ascitic fluid, which is the commonest primary that is metastasizing?
Ovarian adenocarcinoma.
Ovary. Pancreatic tumors, hepatic tumors. These are the common tumors that you're getting. Now, what are you seeing in these smears?
I can see a tight cluster of cells with abundant cytoplasm and vacuolation. And I mean, my first slide is in a background of RBC. In the other slides, you can see mucinous background.
This is also stringent mucin, and this is the histology. So these are cells from mucin secreting adenocarcinoma. Here you're getting a signet ring type of cell. Now here, see, do you people read the RDMM book, Richard McDemay's book? It gives it has 4 volumes to it, and it beautifully highlights the use of mucicarmine stain. Always you need not have the immunochemistry, but you can make good use of the mucicarmine stain. And mucicarmine stains which type of mucin? Neutral mucins or acidic mucins?
Acidic.
Acidic.
No, it stains the neutral mucins. And all the mucin that you are seeing in these tumors, they are neutral mucins or acidic mucins?
Neutral.
Neutral mucins. So it is a very good, it is less sensitive, but it's very specific as compared to the PAS stain. So this was the gross appearance of the tumor and the histology, gelatinous appearance and abundant mucin. Now again, you have some more cells coming from, and here in mucin secreting adenocarcinomas, you get such gigantic cells with huge vacuoles and indenting the nucleus. And here you can see, in contrast, you can see this mucin secreting malignant cells and what are these cells? These are the
Mesothelial cells.
They are
Mesothelial.
Mesothelial
yes.
cells.
Yeah, mesothelial cells, dense cytoplasm, binucleation. Here you can see those blebs, but these are clear-cut malignant adenocarcinoma cells. So now just extending a little bit, which is this? Again, if she's a female with an ovarian tumor, very obvious diagnosis.
Mucinous.
Papillary mucins.
Mucinous adenocarcinoma.
Serous adenocarcinoma. What is this arrangement called as?
Papillary.
Papillary arrangement. You can see fibrous pores and cells coming out of that. These are the broken tips of the papilla. What are these?
Samoma bodies.
Samoma bodies.
Samoma bodies. So you get samoma bodies only in serous adenocarcinoma, or
No,
you
ma'am.
can get them in some benign conditions.
Meningioma.
Who's answering? Someone is telling us. I can hear 2 voices.
Ma'am, meningioma.
But does meningioma come in ascitic fluid?
No, ma'am.
So
Ma'am, there can be benign structures also.
Ma'am,
yes,
mesothelioma.
you can get them occasionally in mesothelioma. You can get them in endosalpingiosis. You can get them in endosalpingiosis. You can get even in papillary hyperplasia of the mesothelium. That also can cause, come up with samoma bodies. So these calcified concentric accumulations of the samoma bodies and these malignant cells makes your diagnosis very easy. So now this is an example of papillary mesenteric hyperplasia with samoma bodies. And this is again serous adenocarcinoma. You have these malignant. So the point here is that the diagnosis is very easy when you have the alien cells with their characteristic features. And because ovary is the commonest site which metastasizes in the omentum, that can be diagnosed very easily if it is a mucinous adenocarcinoma or a serous adenocarcinoma. Here all the nuclear features, etc. are seen. Now, but sometimes when you are in doubt, that is equivocal effusion cytology, straight away it's easy, positive for malignancy. But if it is suspicious for malignancy, what are all you can do? You can go in for a cell block. If it is available at your place, if you are not doing it, it's not available, then it's different. If it's available, you can do immunocytochemistry. And if you are doing it on without second population. Now, what do you understand by second population? which is the primary population in any fluid?
Mesothelial cells.
Mesothelial cells.
So anything apart from the mesothelial cells appearing alien in that area is the second population. Now, when you do not have a cell block facility, you have these suspicious material or suspicious for malignancy, what all you're going to do. And if that suspicious malignancy is with second population, here without second and with the second population. Without the second population, if you have very good quality and quantity of the cells, if they are present, then you have to see that whether it is malignant mesothelioma or not. We'll come to that a little later. With the second population, how you are going to decide whether this is lymphoreticular malignancy? If it is LCA positive, if it is LCA negative, it could be a sarcoma. If it is cytokeratin positive, it could be a carcinoma, and then further you can do all other markers to decide. Now, immunoreaction for negative mesothelial markers you have to do, as I've told you, which is a negative mesothelial marker. EMA. EMA is a negative mesothelial marker. Now, when you have to diagnose malignant mesothelioma, we will come to that case totally. Now, I would still, because I know that most of the peripheral medical colleges, they do not have the facility of immunocytochemistry. We have to keep in mind such simple stains that are always with us. So mucicarmine in mesothelioma will always be, usually will be negative. Why? Because mesenchymal mucin is acidic mucin and mucicarmine stains neutral mucins. In adenocarcinoma, it will be positive. PAS will be positive both before and after diastase digestion. In adenocarcinoma. But in mesothelioma, it will be negative after diastase digestion. Alcian blue will be positive in both. And if you are suspecting mesothelioma after hyaluronidase digestion, the mucin will be digested in mesothelioma and it remains positive in adenocarcinoma. So even I know that diastase is also not available to us many times in medical colleges, and leave apart the hyaluronidase. So you can just take the help of mucicarmine and try to work out as much as possible. And diastase, you know how, if it's not available, what do? You have to put a little saliva on the slide. Dr. Bhardwaj, will you agree to that?
Agree, absolutely agree. We are doing it.
Yes, so sometimes you have to do that when you're desperate in diagnosing, or at least demonstrating it to your own residents, that what all can be done. So past positive before and after diastase digestion would be a adenocarcinoma. Now, what are the suggested immunochemistry markers for reactive mesothelial cells versus adenocarcinoma? Calretinine, Salman, are you there?
Yes, ma'am.
Calretinine will be positive in mesothelial cells.
Yes, ma'am. WT1 will also be positive in mesothelioma.
Yes.
Yes, ma'am. And CK5, 6 will be positive in both the reactive mesothelial cells as well as adenocarcinoma. P53 will be negative in reactive mesothelial cells, but they will be positive in adenocarcinoma. Desmin will be positive in case of reactive mesothelial cells. EMA will be positive in case of adenocarcinoma. MOC31 will be positive in adenocarcinoma. BER-EP4 will be positive in adenocarcinoma, and B72.3 will be positive in adenocarcinoma.
Yes, so you have to select your immunocytochemical markers to take a decision. So this doesn't. Now I think we move to our next case.
Okay, madam.
Any comments, madam?
No, we can move.
Yeah. So now this is pericardial fluid. Whom do I have with me?
Ma'am. Chandan.
You ask Shaila Sutta.
Shaila, please come.
Yes, ma'am. Ma'am, this is a case 4, pericardial fluid from a 58-year-old female of a known case of breast carcinoma. And in the images, I can see that it is a moderately cellular smear where almost the cells are forming cluster, very tight clusters, and I can see a distinct halo around each of the clusters.
Talking about
And
sorry, you're talking about this halo. Okay, that's artifactual.
yes, ma'am.
But
Okay,
basically,
ma'am.
what you are seeing are cell
Are
balls.
cell balls and very tight cell clusters, and the cell nuclei are forming the borders.
Yes, there is
And
a hollow in the center. So there is a
yes, in
hollow
the
in
hollow
the
in the
cell
center.
cluster, which is very typical of such modules or cell balls that come from CA breast. Okay?
Yes, ma'am. And the background is appearing somewhat foamy or necrotic.
No, so cytoplasm is foamy, backgrounds are necrotic. So cannot be
Yes,
foamy.
okay.
What is this
Okay,
you're
ma'am.
seeing? It's just a trail of cells.
A trail of cells and showing some amount of branching, I
Not
can see.
exactly extension of those trails, and they are known as peas in the pod. Now see here, you can see this
Yes,
that
ma'am.
classical appearance, and this is not taken from anywhere. It was present in the one of the fluid pictures when I used to click them. So this has that peas in the pod type of appearance, and very typical of breast carcinoma cells. You have this hollow centered with the malignant cells. Here you have a fry pan type of appearance, then you have this papillary type of appearance. This is a very frank case of metastasis of
Breast,
breast. Yes,
breast
breast carcinoma
carcinoma.
to the pericardial fluid. Sometimes it could be the primary presentation, breast carcinoma going to the pleural fluid. Pericardial is unusual, but the pleural fluid is very common. Now, but as the grade of the tumor increases, as I told you, there can be dissociation of cells. So here, what are you seeing? I just want you to see the morphology of these cells. Describe.
Yes, ma'am. Ma'am, these cells are present in very loose clusters and as well as discretely, having a scant to moderate, almost like scant cytoplasm with a round to oval nucleus, vesicular chromatin, and a very prominent nucleoli I can see. And in between,
And here you
I
are
can
seeing
also, yes, ma'am, there I can see markedly pleomorphic cells with the hyperchromatic nucleus and
this is these are
mitosis.
mitosis. Multiple
Mitosis.
mitosis is I just
Yes, ma'am.
because it's unusual to see so many mitosis. See, this is just these are mitosis. This is not coarse clumping of the chromatin. These are mitotic figures in the process. Okay,
Yes, ma'am.
so you have described it very well. Yeah, you have given a very perfect description. And now we were talking about morules, cell balls, cell clusters, cannonballs. But as the differentiation of the cells becomes poorer, you can get so much dissociation that they start resembling poorly differentiated carcinoma. This is one feature. What is this?
Ma'am, this is a cell ball where I can see that the cells are separated widely and it has a very smooth contour. The cell ball is having a very smooth contour and clustering is present at the polar ends. Like,
But what is the background made of? This is a collagen ball. See, you
okay,
must
ma'am.
have read a lot that you can have just random material coming in the pleural fluid. So one of them is the collagen balls that come, and they are very typically found in CA breast with the malignant cells around them. So this is the collagenous material. Now here, these are cells from gastric carcinoma. What is this appearance known as?
A signet ring.
Signet ring appearance. And what is this appearance known as?
Ma'am, cell within a cell.
Yes, cell within a cell or a cannibalism type. Now,
Cannibal.
both these
Yes, ma'am.
breast carcinoma cells and the gastric cells, they have epithelial mucin in them, which is a neutral mucin.
Okay.
And again, mucic carmine stain is a very good stain. PAS D stain, it is highly sensitive, but it is less specific. and you can go for it in breast, lung, and gastric carcinomas. But because of many difficulties in interpretation of the same cells in the same smear before they are stained and after they are stained, so the specificity and is becoming lesser and lesser, and our inclination towards immunocytochemistry is increasing. What do you say, madam? We are becoming more and more inclined to diagnosis using cell blocks and immunocytochemistry. Now, what are the suggested adenocarcinoma markers? See, any marker which is negative both for the benign mesothelial cells and the reactive mesothelial cells, I mean benign and reactive mesothelial cells and the malignant cells, becomes a very good marker for your adenocarcinoma. So now you have these three markers. Can you read it out?
Yes, ma'am. Ma'am, B72.3, which is positive in case of adenocarcinoma, but EP4, which is again positive in case of adenocarcinoma, and CA99, which is positive in case of adenocarcinoma of the
So
gastric
these will
breast.
be negative in all the mesothelial cells, and then
Mesothelial cells.
and even in mesothelioma. So you can be very sure that these whatever you are seeing are adenocarcinoma cells. Okay, any questions? Now again in the breast you have the second type of malignancy. What are you seeing here?
Ma'am, I can see a very it's a tight cluster of cells which are having a very irregular outline, and the cells are having moderate to scanty cytoplasm, and the cell borders are very fuzzy, like very frilly. It is appearing.
There's a lot
No
of
distinct
cells within, and
boundary.
cells are small. They are pretty small. And here you can, in this, this was again a 45-year-old female who presented with pleural effusion. So what are you seeing in these cells?
Ma'am, in these cells, I can see multivacuolated cell. Yes, ma'am. Here I can see multivacuolated cells.
No, single vacuole. In each of the cells, you are seeing a single vacuole. The cell is small. What is this in cell?
I can see, ma'am,
A targetoid inclusion.
multinucleated.
No, there is no multinucleation here. There is a targetoid inclusion within the vacuole. When does it come? In which malignancy does it come? Breast malignancy?
Lobular carcinoma.
Yes, you get it in lobular carcinoma. Here you're getting these small cells with vacuoles, but always the targetoid inclusion may not be seen in each of the vacuoles. But these cells that you are seeing, they are the reactive mesothelial cells, and this is again a reactive binucleated cell. And these now another feature of lobular carcinoma is, tell us, come on.
Ma'am, it is an Indian file in cell behind a cell. I think I can appreciate that in this.
Yes, in this one. Here also there is stacking of cells. There is molding of the cells. The high grade of the nucleus here. Sorry, to show you that once again. Does it help when I zoom? See,
yes,
here you have that
Yes,
half moon type of appearance, coarse chromatin, and small cells with hardly any cytoplasm. This is an oil immersion, and plus we have zoomed it to see the features nicely. So the other variety that metastasizes is the lobular carcinoma of the breast. And then you can have confirm the malignancy using the immunocytochemical markers. Now coming to the malignant primary, the boss of the all the cavities of the body. Who do I have as a boss describing this? We have Dr. Anyone, please volunteer. Even Bonita can do it, or Bonita can ask somebody to do it.
Ma'am Chandana, have you?
Yes, ma'am.
Please go ahead.
Malignant mesothelioma. We have.
I don't want you to read all about this. Now, we should first thing, what would be the difference between reactive mesothelial cells, hyperplastic, hypertrophic, and how would you differentiate them from malignant mesothelioma cell case? So these are the features. What would be the cellularity will be like? Now you can read it.
Supercellular smears with high, moderate, or low cellularity. Cell type is mesothelial, non-mesothelial, or both type of cells. With cellular atypia, obviously malignant. With suspicious atypical or benign cells can be seen. Gross findings of serous effusions frequently manifest as large volumes of effusion that tend to rapidly recur, usually amber in color that can be red due to blood, very viscous with a tar-like or honey-like consistency correlating with high hyaluronic concentrations.
Yes. Now, this picture I have focused, this is from Dr. Shidham's book, and he has this series of SEMA's fluid cytology books. They are very nice books, you can read them. And here you can see these mesothelium. Can you recognize them as mesothelium?
Yes, ma'am.
Yes, why? We must repeat the features once again.
These cells have windowing in between them. They're like at
We will not call windowing, the windows between them.
windows between them.
Clefts or windows, yes.
With some cells showing a fraying of cytoplasm.
Yes.
And, centrally to eccentrically placed nucleus with prominent nucleoli.
Yes.
And the dual tone cytoplasm can be appreciated in few cells.
So this cell is pretty abnormal. This is also very abnormal. Here again. So you have larger cells with larger nuclei, more cellularity, more number of nucleoli and larger nuclei. So everything is big, big, big and more in numbers in mesothelium. But as we have seen that even the reactive mesothelial cells can become very bad, sometimes creating suspicion of malignancy. So would you like to call this as suspicious for mesothelioma or just straight away put it as
Suspicious.
Suspicious for, you feel that you can call it suspicious for mesothelioma. Yes, so by and large you have a complete range of reactive mesothelial cells except for 1, 2, 3 and 4 of these cells. So you would be justified. Now here what is happening? What are you seeing?
There are fine vacuoles in the cytoplasm and a few clusters or balls kind of structures are seen.
Yes. Now in these balls and clusters, sir has made it very clear that the nuclei, they are almost jutting or abutting the cytoplasmic membrane. So that is a feature of malignant cells. All these cells, they may look highly abnormal with high NC ratio and all other features, but still you can get even this frilling and vacuolation even in malignant cells. But this type of features is very specific for malignant cells. When you get the nucleus touching the periphery of the cytoplasm. So here now would you like to call it benign or malignant?
Malignant, because of those clusters or balls with nucleus pushed.
Here in this you have again they are resembling the family of mesothelial cells, but I would put it as suspicious for malignancy. Now I have straight away come to these. I don't know why this slide has come. Just let me. Yeah, I want to show you more of these features. Now, this smear, what would you describe it as? Come on.
Smear is highly cellular with tumor cells scattered in the smear with cells are polygonal with central to eccentrically placed nucleus, showing a prominent nucleoli with a moderate amount of cytoplasm.
Now, what is telling you that it still belongs to the mesothelial family? The two-tone cytoplasm?
Yes, ma'am. Two-tone cytoplasm with windows between
margins of the cytoplasm?
Yes, ma'am.
Yeah. Central large nucleus, but then they are highly atypical and there are too many of them. Here again, you have these bad cells, but what you have that is vertebra-like arrangement. There is articulation of these cells and vertebra-like arrangement with little clefts in between. So you feel that they could be malignant mesothelial cells?
Yes, ma'am, that could be malignant mesothelial cells.
So these are examples of highly malignant mesothelial cells. Now, what is this blue color inside the cytoplasm? And something in the background. This blue granular material is the hyaluronic acid. And this is the cytoplasm. Yes, it takes like this pale blue color. So these are subtle indicators or clues that tell you that you are dealing with malignant mesothelial cells. Plus the supercellularity, supercellular smears with all the abnormalities and the cells resembling their original progeny or their kinship with the normal mesothelial cells makes you, tells you that they could be malignant cells. Now again, this I have, this is the thick and thin smear with so much of cellularity. But here I wanted to demonstrate this blue color of the hyaluronic acid.
Sometimes it gives a magenta hue also, the hyaluronic acid.
Yes, it can give, but then in that case you confuse with other mucins.
Yes.
Yeah, neutral mucins or acidic mucins. Yeah, so see these cell balls and cell clusters. Now another feature is what is this you are seeing over here?
Cluster with a knobby border can be seen in this one.
Yes, exactly. I'm very happy that all of you have read very well. Your descriptions are very good. And now you have these. Now, whenever we say that they have knobby borders and all the nuclei, they are touching the cytoplasm, it's not 100%. Understand? Here, see, they are not touching. Most of the nuclei, they are not touching. But overall configuration, overall appearance, and overall knobby appearance of the cell cluster and atypical nuclei tells you that. And this hyaluronic material inside in the form of pale blue material is indicative. Here you have these malignant cells coming. And then what is this? This is a lot of
Invisible body
this is
macro.
karyorexis. This is not multinucleation, this is just karyorexic. But then this is giving rise to another baby ball of cells. And these are all features of high-grade malignancy. Okay. Now, another feature which has been very distinctly described in all the books, even in the TIS classification and other places, is that you have this dense orangophilic or keratinized cytoplasm. You have this. So, are these malignant squamous cells? Some amount of keratinization. Yes? Somebody said something?
Ma'am, that is pseudokeratinization.
Yes, perfect. You have read it well. This is pseudokeratinization, and they say that presence of such cells is almost very diagnostic or highly favoring a mesothelial malignancy. So, and this is simply a degenerative phenomena. So, you have very bad phases of these malignant mesothelial cells, which you have to recognize with practice. Then you have these cell balls and cell clusters. Now, see, these cell balls, how large they are. All of them are not having knobby borders, but they are having these clefts inside them. They are still resembling their progenitor cells or the benign counterpart. And in this you are seeing and you sometimes you do get collagen balls also in these cells. Now, this is a cell block of a mesothelioma. Here you can see the clasping effect in this with the malignant nuclei. I think you are pretty clear. We have to choose two markers that are positive in the mesothelial cells and two markers that are negative for mesothelial cells. And that is how you can come to a conclusion. We have dealt with this. Now let's move to the last case. It's a very simple one, but very, madam, any comments?
No comments, ma'am.
Okay. Now this is anybody just describe the history.
Any volunteer?
Purnika, you can do it.
Ma'am, 29 years old female, history of shortness of breath in for 3 weeks, cough and right-sided chest pain, and cytology. On imaging, they're saying that there is possibility of lung metastasis over infective etiology.
Yeah. Now, this is what we saw in the pleural fluid cytology. Again, what are these? How will you describe them? Abundant cellularity.
Abundant cellularity with cells which are arranged in clusters and also few dispersed singly.
Cell balls.
Cell balls are noted.
Yeah, and then you have these proliferation spheres also, that is what you call sometimes. These are the proliferation spheres, one coming out of the other. And see, the whole thing acts like a culture medium, and it's very conducive to the multiplication of the cell, the fluid in the body fluid. Yes, describe this. It has, what is this called as? Smooth community borders, which is a feature of metastatic malignancy. Otherwise also in adenocarcinoma cells. Now, can you recognize the cells within?
Ma'am, the cells. Ma'am, the cells within that clusters could not be well appreciated, but I could see that there is round to oval cells with that hyperchromatic nucleus, ma'am.
There is swirling and whirling of the cells. They are spindly.
Yes.
They are not the epithelial, typical epithelial cells that we saw.
Yes, ma'am.
Polygonal, they are not those types. They are spindly. Here you can appreciate the spindle nature of the cells. Now, are these epithelioid cells? Because tuberculosis is so common in India, first thing that comes to your mind is epithelioid granulomas.
Yes, ma'am.
So, do you feel that these are epithelioid cells?
Ma'am, I felt that was epithelioid cells, ma'am, because in the first picture, when I zoom it, that there are few cells which are spindle to epithelioid in shape.
Yes, but then they are proliferating in a very regular manner. We see that the background and the associated, of course, we also entertained the diagnosis of tuberculosis in this patient for a very long time. And now then we came to an impression that this is a spindle and epithelioid cell tumor with mild to moderate nuclear atypia, primary versus metastatic. And then we kept these possibilities, mesothelioma monophasic. Now we know what are the different types of the mesothelioma that you have.
Ma'am, it could be epithelioid, it could be sarcomatoid, or it could be biphasic, ma'am.
So could this be a sarcomatoid variant of mesothelioma?
Yes, ma'am, could be.
So we also entertain that it could be a fibrosarcoma, it could be a leiomyosarcoma, it could be a smooth muscle tumor of the pleura, or of course tuberculosis could not be ruled out in this patient. Now, what was the missing link that after a long time, let's say 1.5 months, the patient came with history of hysterectomy 1 year ago. She gave us the history of hysterectomy 1 year ago, and then we asked for her blocks and from the uterus and the cervix, and what we saw, we got even the description of the gross pictures, and there was a gray white world, a mass in the uterus with no necrosis, no hemorrhage, and cervix was unremarkable. And the histopathologic diagnosis given by one of the practicing pathologists was leiomyoma. Now, with this, in this light of this report, we thought that it could be a benign metastasizing leiomyoma. So we know that there is an entity like this, that is BML, or it could be a low-grade leiomyosarcoma of the uterus, lung, or the pleura, giving rise to this type of pleural effusion. And then we reviewed the slides, we reviewed the biopsies from the pleural nodules, but somehow we couldn't, we still had material with us. We had these slides, cytology slides, so we scraped, we destained them, and we did a Masson trichome stain by the time we got our immunocytochemistry done, and the cells turned red. So as I was emphasizing that you can do your routine stains before embarking on immunocytochemistry. So we were sure that we are dealing with smooth muscle cells because Masson trichome stain was positive, and her histopathology showed a leiomyosarcoma of the low grade type, which was metastasizing to the pleura and giving this type of appearance. So I think this is all that I have to show today. Madam, if you have any comments, please tell me.
The slides are very good, madam, and the talk is also very nice. Excellent, madam.
Thank you, sir. Thank you so much. I wish I could have, if you have any questions, please go ahead. Bonita and Poonam, are there any questions in the chat box?
As such, no such questions, but only one question that has been already covered. ISC to differentiate mesothelial cells from malignant mesothelioma. That is,
Yeah. So I told you two markers that are negative, that is BER EP4 and CA 19.19. You can choose that, and two other markers that are positive for epithelial cells, that is the either EMA and vimentin that can be taken, and then you can decide upon. There was so much to show you more, but I think there are time constraints.
Yes, madam.
Ma'am, the last case was a very challenging case, I must say.
Yes, yes, it was very challenging.
Because the chest X-ray appearance, it's showing almost a complete honeycombing of the lungs. So the clinically, it's difficult to say that it could be some benign entity.
Exactly.
It looks like a malignant case only.
I just kept it because, I mean, there are a lot many details in that to discuss. I just kept it to show that sarcomatoid variant of mesothelioma can sometimes come like this, but it's less common. Epithelioid variant is more common. So, and it could turn out something very different, unexpected.
Thank you, ma'am. Thank you very much. It was a wonderful presentation.
Thank you.
We learned a lot
And
from this.
fluid cytology, it is the final interpretation should be made or should be based on the collective informations. And that is also very important, like the last case. So thank you,
It's
madam.
not one finding. It's not one finding. It is a constellation of
Yes,
multiple.
collection of informations, then only the diagnosis is easy.
Yeah, and we have to really hunt for the history, clinical details, go into
Madam,
the past history.
we have to look after so many important issues, and these ancillary studies only provide objective confirmation.
Yes. And for coming to a conclusion whether ICC should be done or not, our morphological basis has to be very strong.
Yes, madam.
And
Thank
I
you.
really compliment all the students. They were very well read. Their direction of description of the cells was very good. And I think it was because of their reading and that they had that direction of description and observation. Thank you so much.
Thank you
Thanks
so
a
much.
lot, ma'am. Thank you.
Thank you, Dr. Kamal, for such a wonderful presentation. And you covered all the cases from the different categories of the TAS international system. And the session was indeed very informative. Ma'am, one of the student is asking for which book to read for fluid cytology.
I think even Bibo is very good. TIS is at present very good for you, and the RDMM is good. Richard D. May, the book on exfoliative cytology, and even Siddham sir's book of fluid cytology on serous effusions is very good. Dr. Siddham's CMAS 2, the series of CMAS 1, 2,
Sibas
and
also
3.
is a very good.
CMAS 2.
Okay, right.
CMAS 2 of Dr. Siddham is very good and very detailed observations and everything about fluid cytology, cell block, his new technique, the skip method that he's doing. So that's very good.
Ma'am,
Thank you, ma'am. And
loaded with
many of the
thanking him.
participants are showing appreciation in the chat box for the wonderful presentation. I would also like to thank Dr. Bhardwaj and Dr. Pradhan for sharing their insights about the fluid cytology through the vast experience that they have gained. I would also like to thank the students for their very active participation in the seminar, and also to the online participants
for their patient listening. With this, I would like to end the session by sharing